Hi, everybody. If you've got your lunches now, we're going to go ahead and get started. So welcome to this 3M Lunch Symposium, and thank you so much for taking the time to come. And be sure to, if you haven't already, avail yourself of the Avogard D hand hygiene that we have out there and the 3M masks. Keep you safe on your trips back home. And with that, I would like to introduce our speaker. First of all, I'll introduce myself. I'm Laurel Wickman. I'm a marketing manager at 3M in our Medical Solutions division, working primarily in the operating room segment. And we are the sponsor of this program today. And Linda Cunningham is our speaker. And I will give you a little introduction to Linda. Linda graduated from the State University of New York in Morrisville with an associate degree in applied science and nursing and obtained her Bachelor of Nursing degree from Emmanuel College. She's been a registered nurse for 36 years. Linda has worked the past 26 years as an operating room nurse at New England Baptist Hospital in Boston, Massachusetts, where she conducted nursing research. One is comparison of esophageal probe and zero heat flux sensor thermometers, chasing hypothermia in the orthopedic patient, the effect of patient-controlled preoperative warming on incidence of hypothermia in total joint arthroplasty, a randomized study, and preoperative warming and its effect on meperidine usage in the post-anesthesia care unit. So with that, I will welcome Linda.
Thank you, Laurel. And thank you for coming and spending your time here for this lunch symposium. This was a couple housekeeping slides. This was just some 3M keeping our event safe information. So my talk today is the efficacy of ERAS-compliant perioperative normothermia protocol, strategies and best practices to increase efficiency and improve outcomes. This is just a bit of housekeeping slide. My talk today is based on my personal experiences with 3M products. So if I can't answer any of your questions about them, I would refer you to the 3M website or your local 3M rep. And my full disclosure is that I am a paid speaker for 3M. So our objectives today are to identify which ERAS guidelines recommend intraoperative normothermia. And actually, we can meet that right now because all ERAS protocols have a component for intraoperative normothermia of maintaining it. And the second one is to discuss the components of the ERAS-compliant normothermia protocol, demonstrate ERAS-compliant perioperative normothermia protocol efficacy to help reduce post-op complications via outcome reviews, examine the role of active warming using forced air warming in helping to prevent inadvertent perioperative hypothermia, and identify the benefits and advantages of the non-invasive continuous core temperature monitoring system using a zero heat flux thermometry. So I hope I didn't lose you in the objectives so far, because there's a lot of them there. But my talk is basically here today to help you appreciate the important role that normothermia and maintaining normothermia plays in your ERAS protocols, and to appreciate the potential post-op complications of hypothermia that can present for your patients. So the importance of normothermia maintenance in ERAS. So ERAS, we're all here. I'm sure you've listened to talks all these last couple of days about the programs that are implemented all over the world that positively impact patient outcomes, reduce hospital length of stay, and increase hospital efficiency and reduce costs, because that's what we want. We want good outcomes and low costs. And they were initially centered on the colorectal patients and the abdominal patients, and that was in about 1997, and they have just expanded to all surgical services because they work. You might have noted in the past that they were noted as fast track or accelerated rehab or rapid recovery. And I was introduced to accelerated rehab as an orthopedic OR nurse. And all I really knew about it is that the patients were selected who were having total hip replacements. And then they would be accelerated rehab, and I would put some TEDs on them post-operatively, and they'd go over to the stretcher, and when they were ready to go to the floor, the physical therapist would meet them up on the floor and walk them to their room. And that's kind of all I really knew about accelerated rehab. But what I know now about ERAS is that it is a multidisciplinary patient-focused approach to surgical care. And there's so much more to it. And I've listened to some talks this morning about educating everybody along the spectrum, because all of these pieces need to come together. So in the pre-op stage phase, this is the pre-op team, as we know, manages the risks, looks at our patients' comorbidities, their nutrition, the whole new take on fasting, about not starving and dehydrating our patients before surgery, giving them carbohydrated loaded drinks, DVT prophylaxis so we don't get into any problems with PEs, and of course pre-op education, a huge piece of that we've been listening to in the last couple of days. In the intraoperative phase, it's all about selecting the best anesthesia type for the patient and the procedure they're having, and maintaining normothermia. That's in, like I said, that's in every ERAS protocol, and that's a real important piece of these protocols. And fluid management, as we know, we just listened to a talk about kidney injury. So all of that takes place intraoperatively, and then postoperatively, selecting the appropriate pain medication for the right duration, minimizing post-op nausea, vomiting, and early mobilization. So there's a great article written in 2015 by Helena Edis, and it looks at the ERAS protocols and the role of patient warming. And this was published basically to underscore the importance of maintaining normothermia combined with accurate and consistent temperature monitoring. And the goal of maintaining normothermia should be the focus at every stage of the perioperative process to contribute to a positive patient outcome. So we want to look at warming preoperatively, intraoperatively, and postoperatively. And these are the healthcare organizations around the world that have recommendations or guidelines emphasizing the importance of perioperative temperature management. So you can see next to the US flag, we have all the heavy hitters, the Association of Nurse Anesthetists, the ASA, American Society of Perianesthesia Nurses, Association of Perioperative Registered Nurses, all the way down through the Joint Commission. So everybody has a piece of this, and it's all around temperature management and having them in the ERAS guidelines. So let's talk about inadvertent perioperative hypothermia. It's also known as IPH. And it's defined as a core body temperature less than 36 degrees Celsius or 96.8 degrees Fahrenheit. And the key here is core, not just body temperature, a core body temperature less than those temperatures. And is often considered a frequent and preventable complication of surgery. And research shows that even mild hypothermia can result in significant negative outcomes. And unless we do something to prevent hypothermia, it actually can occur up to 90% of our patients. So I think it's a common occurrence and it's often underappreciated. And like I said, it's in the ERAS protocols, but it's kind of down at the bottom. And it's not, I don't think that we don't care about it, but I think it's just really not on our radar. I think that we look at keeping our patients warm. There's a lot going on in the preoperative area, getting the patient ready for surgery. Then they go to surgery and then to the PACU. And there's so much going on that we try to keep our patients warm. But what really is our patients being hypothermic, and what are those complications that they could get from being hypothermic? And what's important is that anesthesia triggers this redistribution temperature drop. And this occurs regardless of what type of anesthesia the patient has, whether it's general, spinal, epidural, or monitored anesthesia care. And coupled with that, the patients lose their ability to thermoregulate their body temperature. And core temperature can drop 1.6 degrees Celsius in the first hour of general anesthesia with that core temperature drop. So the causes of inadvertent perioperative hypothermia. The biggest part is that redistribution temperature drop that I was telling you about. And I like this figure because it really is a good visual on what happens when patients undergo it. So if you look at the image on the left where the patient is warm in the core, so the core area is nice and warm, it's red. And this is where we normally sit, it's where we sit now. And it's very tightly controlled. It's all our vital organs are here, and if it gets out of whack, we either sweat to cool ourselves off or we shiver to warm ourselves up. And what the problem is that our core temperature is 2 to 4 degrees warmer than the blood in our peripheral system. And so when the patients undergo anesthesia, whether it's general or spinal, whatever it is, they undergo vasodilation. And that causes the warm core blood to head out into the periphery, mix with our cool blood, and come back and dump our core body temperature. And that's that redistribution temperature drop. That's about 80% of why patients have a hypothermic event in the operating room. The other 20% comes from exposed body cavities. So I always think in my orthopedic world of the big scoliosis cases or the big hip revisions that are done, from top to bottom, but your abdominal cases, anything that's got a big wound open, that can contribute to IPH. The cold operating room temperatures, not a whole lot you can do about that. You don't want your surgeon or your surgical team sweating into the wound or onto your sterile instruments. And length of surgery, that would tell you that if you're in there longer, you're more likely to have an episode of IPH. And also the infusion of cold fluids and blood. So if your anesthesia team isn't warming their fluids or their blood, that also contributes to IPH. So negative outcomes for IPH, and these are well documented in the literature and have been for years, but they're significant and they're worth talking about. So the first one we'll talk about is surgical site infection. And studies show that patients who are hypothermic have vasoconstriction, and it also lowers their level of oxygen to the wound bed. And they also believe that the antibiotics that are given preoperatively don't head to that wound bed because of the vasoconstriction going on due to the hypothermia. And I would encourage you, if any of you sit on your infection prevention teams and you do your monthly reports and you sit down and discuss, why you had surgical site infections, how many, what could you have done differently, were the antibiotics in time, I would add hypothermia to that list because I think you'd be really shocked at how hypothermic patients are during their surgical course. There's also problems with coagulopathy. This is well documented as well. And it can alter the function of your platelets. And even though you have normal platelet values, the function is the inhibition of the initial platelet plug. So all these things are going on behind the scenes. And there's studies that show that if patients are mildly hypothermic, but between like 2 degrees, from between 34 and 36 degrees of their temperature, they are will likely bleed 16% more than if they're normothermic. And their risk of a blood transfusion can go up to 22% just from being hypothermic. So then I'm going to talk about shivering and thermal discomfort. So I don't know if anybody in the room has ever had surgery and woke up shivering, but if you did, you probably will never forget it. And it's a huge patient dissatisfier. I can't tell you how many times I've been in the operating room seeing my patients preoperatively, and they talk to me about being so cold after their last procedure, and they plead with me, do not let me wake up shivering. And it's kind of interesting because patients actually look at it more than the pain they had postoperatively. It can be more painful to them than actually their post-op pain. And it brings me to a discussion I had with one of my colleagues who went to a bigger Boston hospital, and he had a craniotomy for a benign brain tumor. And he recovered, he did well, he came back, and I asked him, I said, how was the nursing care? Because it's kind of like the competitor in me. I kind of want to know, how was the care over there? And the first thing that he said is, I woke up so cold. And I thought, wow, out of everything he could have said about his time in this hospital, he talked about how cold he woke up. And so it's not a benign condition, especially when related to patients who have altered cardiac status or pulmonary status, because when patients shiver and get into rigors, they can increase their oxygen demand by 200%. And all of those things can add up to myocardial events or cardiac arrhythmias, if your patients, we're doing sicker and sicker patients. So that shivering is a huge component. Also, if they're hypothermic, they will have delayed emergence from anesthesia. And I've seen this in my own practice. If we have a slow wake up in the operating room and patients are taking a long time, if you look at their temperature, they're hypothermic. And so they're not processing those meds during surgery because they're cold. And so you're going to have delayed time, wake-up time in the operating room and delayed time getting them out of the PACU. And all of these things add together, all added up increase the mortality rates of patients. They're all big risk factors, and it strictly comes from having episodes of IPH. So this was our challenge, and it was to measuring core body temperature in the perioperative course. So patients would come in, and they would get checked in, and they would get their temperature taken via a temporal scanner. And the kind we used was the kind that swiped across the forehead and touches behind the ear. Not know if you're familiar with that. And then the patient would go into surgery, and we would take their temperature with an esophageal probe. And that would be our only real way to measure core body temperature, because that was our only method of measuring core body temperature. And then they would be extubated, and of course they can't tolerate that esophageal probe, and it would be taken out, and they'd go over into PACU, and again we would swipe them with the same device that we use preoperatively. And this was always a conversation among my colleagues at work, is that when we bring our patients to the PACU, we could have this huge case going on, this big hip revision that took hours, or a knee revision, and every time they swiped the patient, they got 97.4. 97.6. And you're thinking, how can that be? They were hypothermic in the operating room and they're normothermic in the PACU. And then if they got a low one, the nurses would go to the other side to see if they could get a higher temperature, and then kind of pick the highest one they could get. So we never really trusted it, because it never correlated between the pre-op, from pre-op to the intra-op to post-op. So I just wanted to say a little bit about the distal esophageal probe, that it's invasive. It goes down into the esophagus after the patient is intubated, and the temperatures can vary according to placement, because there's no real way to check where that probe is. It's not accurate with a laryngeal mask airway, so I'm not sure if you all know what that is, but when patients are needing general anesthesia and they don't necessarily need to have an ET tube placed, they'll use this LMA device, and it's a big kind of plastic thing that goes in their mouth, and it works as an ET tube without having to go down into their, past their cords. And there's so much going on, you can't get an esophageal probe in there. Doesn't pass by. So patients who are under general anesthesia with an LMA were getting no temperatures, no core body temperature monitoring intraoperatively. And it's very limited in its use, because it can only be used in patients that are intubated and under general anesthesia. So I was introduced to this new product from my local 3M rep, and it was called the Bear Hugger Temperature Monitoring System. Actually, before that, it was actually known as Spot On, but they changed the name. And my rep told me that it was this new technology that was a zero heat flux sensor that goes on the patient's forehead, and it created a zone of perfect insulation, allowing the warmer temperature to rise to the skin surface where the core temperature can be measured non-invasively. And she told me that it was easy to apply, and it would give us continuous, accurate, and consistent core body temperature in the pre-op operating room and in the PACU. So I took the information to my anesthesia colleagues, and I'm sorry if there's any in the room, but they're a rough crowd, and they did not trust it. They said, how can something on the forehead possibly give us core body temperature, even though the testing that was shown it correlated to the PA catheter really well? But even with the information, I really couldn't convince them. They're used to much more invasive ways of measuring core body temperature. So I thought to myself, well, why don't we do some nursing research? So we decided to compare what we were currently using to this new system of BH. It's the Bear Hugger Temperature Monitoring System, and I'll refer to it as BHTM because it's a lot to say. So basically, the patients would come in and have their temperatures taken with the temporal scanner in the pre-op area and in the PACU, and they would have the esophageal probe in the operating room. And they would also have the BHTM system in use, with the sensor placed on the forehead. So we received IRB approval, and we conducted a prospective paired comparison of 200 patients who underwent elective primary hip and knee arthroplasty in July and August of 2013. And we only selected patients having general anesthesia because we had to compare the esophageal probe to the BHTM system with the sensor. And we chose 6 test points. The first one was the initial check into the pre-op area for a baseline. Upon leaving for the operating room, at the surgical timeout, 1 hour post-incision, and check into the PACU and discharge from the PACU. And these were our mean average temperatures in Fahrenheit for all those test points. So the first 2 was initial check into the pre-op area. Our N was 154, because like I said, we set out for 200 patients, but we only had 154 complete data sets for which to analyze our data. And in the temporal group, it said we had a mean temperature of 97.46. And in the BHTM group with the sensor, there was 97.66 as a mean temperature. So that was a difference of 0.19. Then when they left for the operating room, using the temporal scanner, we had a mean temperature of 97.46 and a mean temperature with the BHTM of 97.68. So it was a difference of 0.22. And then at the surgical timeout, so our surgical timeout is done when the patient is in the room, they're intubated, we have put in our esophageal probe, we've positioned, we've prepped, draped, and we're ready to make our incision, and that's when we call our surgical timeout. So at that point, the esophageal probe is in place, so the mean temperature using the esophageal probe was 96.10, and using the BHTM, it was 96.23 for a difference of 0.13. And I'm just going to back up a little bit here, because if you look at the previous temperatures before they left for the operating room, they were 97.46 and 97.68. And when you were 1 hour surgical, at our surgical timeout, they've dropped to 96.1 and 96.23. So that's that redistribution temperature drop that I showed you. That's real, it happens. And I had read about it a lot and been to conferences and never really appreciated it till I saw it with my own eyes. That's happening. It's happening for everybody who's having surgery, and it can go on for 45 minutes to an hour after surgery. So the patient is still dropping their temperature if nothing is done to help mitigate that. And then at 1 hour post-incision, that redistribution temperature drop is leveling off, and the esophageal probe group, the mean temperature was 96.81, and in the BHTM it was 96.89 for a difference of 0.08. So as you can see, they were correlating pretty closely with the esophageal probe and the BHTM. And this is where things went kind of crazy. So it was in check into the PACU. So now, of course, the esophageal probe is taken out, and we're back using the temporal scanner across the forehead. And using that, it said our average temperatures were 97.69. And using the BHTM, that's been the sensor that's been on from the pre-op area to the operating room into the PACU, it said our mean temperatures were 96.37. So that was a difference of 1.32 degrees. And I can tell you that patients don't warm up in the transition from the operating room to the PACU. I don't know how many people in here are in that realm, but that's probably the second coldest part of surgery, because we're irrigating their wounds, we're closing them, we're exposing them, taking off the drapes, put them onto the stretcher or the bed, and extubating them, and they don't warm up. They actually get colder. And as you can see in the previous slide in the BHTM, their 1 hour post-incision, they were at 96.89. And check into the PACU, they were at 96.37. So they got colder according to that system. They definitely don't warm up. And then discharge from the PACU, the mean temperature using the temporal scanner was 97.62. And using the BHTM, it was 96.83, still for a difference of 0.79 in the temperatures. So then we thought, when we saw this, we thought, wow, do we have a hypothermia problem that we had no idea we had? So we looked to crunch our numbers as far as hypothermia rates went. So we took those same 154 patients, and we looked at hypothermia rates. And initial check into the PACU, we had 9% of our patients who were hypothermic. And I'm going to round these numbers up or down just to make it easier. Using the BHTM, it said we had 14% of our patients that came in hypothermic. When they left for the operating room using the temporal scanner, we still had that 9% that were still hypothermic, and BHTM, 7% of our patients were hypothermic. At the surgical time out, we had a hypothermia rate of 73% using the esophageal probe, and using the BHTM, our rate was 71%. So again, the rates are correlating pretty close. 1 hour post-incision, we had a rate of 46% using the esophageal probe, and using the BHTM, it was a rate of 43%. And then back into the check into the PACU we go, and things still don't add up. According to the temporal scanner, it said that we had 2% of our patients that were hypothermic on transition to the PACU. And using the BHTM system, it said our hypothermia rate was 63%. And discharge from the PACU, we had 3% according to the temporal scanner, and according to the BHTM, we had a rate of 45%. So we sent 45% of our patients to the floor from the PACU who had never achieved normothermia. So then we thought, well, now we know we have this problem, what could we do? So we did some research on pre-warming, and could it help us lower our hypothermia rates? So pre-warming is the application of heat prior to anesthesia for the purpose of increasing your total body temperature. And your total body temperature is the average combined temperature of the periphery and the core. Remember I told you there are two different temperatures where we normally sit. And if we pre-warm our patients, we can essentially bank some of that heat because the pre-warming device sits on the core and it kind of does some banking of the heat to help increase that total body temperature. And the pre-warming is done prior to induction, and this helps maintain normothermia and mitigate the effects of that redistribution temperature drop that you see on every patient who has anesthesia. So then we went into phase 2, which was a prospective randomized controlled study. And we had IRB approval, and we chose 200 patients having total hip and knee arthroplasty to keep it the same. Again, we stayed with general anesthesia patients, and we chose to do our core body temperatures using the 3M BHTM system for all of our temperatures, because we really wanted to see how they did it preoperatively and in the PACU. And so our patients were randomized into 2 groups. The first one was our standard of care group, where they got the cloth gown and the warm blankets. And in the warming group, they got the Bear Hugger warming gown. And I'm not sure how many people are familiar with it. I know 3M had a table out there with it on it, or if you've even used it yourself. But it's a warming gown that has these warming coils in it that connect to that machine. And it's like a hairdryer. And the patients can regulate it so they can be as warm or as cool as they want. And that was the gown we chose to do our pre-warming with. And when the patients went into the surgery, we stuck with our standard of care, which we used the 3M Bear Hugger warming blanket system. So if the patient had a total knee, you were warmed. They had an upper hugger that looked like that. And if they had a total hip, their upper hugger looked like the total hip arthroplasty. And at this point, we weren't doing any anterior hips. All of our patients were done in the lateral position, so that's what our Bear Hugger was placed. And then postoperatively, if you were in the standard of care group, you went back to the cloth gown and the warm cotton blanket. And if you were in the warming group, you went back to the Bear Hugger warming gown. And these were our hypothermia rates comparing the standard of care to the Bear Hugger warming gown. So the same 6 checkpoints, initial check into the pre-op area. We had a rate of about 8% of patients coming in hypothermic, and in the warming gown, we had 6%. And so our patients actually are coming in hypothermic. A lot of people run hypothermic even just coming in. When they left for the operating room, we had 2% that were hypothermic in the standard of care and 1% in the Bear Hugger warming gown. At the surgical timeout, we had a rate of 55% in the standard of care, and in the Bear Hugger warming gown group, we had a rate of 47%. 1 hour post-incision in the standard of care group we had a rate of 23%, and in the Bear Hugger warming gown, 14%. Check into the PACU, we had a rate of 40% in the standard of care, and a rate of 28% in the Bear Hugger warming group. And you can see that rate went up from the transition from the operating room to the PACU. And then discharge from the PACU, the standard of care was 24%, and in the Bear Hugger warming gown was 11%. And so the p-value of 0.02 was only statistically significant in the discharge from the PACU. But I think what's important to see is that if you were in the warming gown group, that there were lower rates of hypothermia in the warming gown group. So then my third phase sort of came around by accident. So after I did my research, we took it to our administration to see if we can warm our patients, because we really believe that we can mitigate that redistribution temperature drop and some potential post-op complications. And they bought into it. So we started warming our patients, and we also put in the BHTM, and all of our patients were getting their temperatures taken with the sensor. And this came out by accident because as we were warming the patients, the PACU nurses were coming up to me and saying they were giving less Demerol or meperidine for shaking rigors. And I thought that was interesting because I thought, well, why don't we just take a look at the numbers and see if there's anything to it. So I looked at the numbers of meperidine in the PACU given in 2015 prior to the implementation of pre-op warming. And we compared that data to 2016, 17, and 18 after we implemented pre-op warming. So in 2015, prior to warming, we gave 846 doses of Demerol in the PACU for 10,570 cases. So that was 8% of our population. In 2016, we gave 531 doses in the PACU for 10,202 cases, which is 5% of our patients. In 2017, we gave 375 doses in the PACU for 10,555 cases, or 3.5% of our patients. And in 2018, we gave 335 doses for 10,194 cases, so for a rate of 3.2. So in 3 years, we decreased the amount of meperidine or Demerol that we used in the PACU by 511 doses. And I thought, wow, this has got to be a cost savings. I was hoping Demerol was $100 a vial. And I thought, because the administration will be so happy that we did this since we implemented it. And Demerol is 88 cents a vial. So there was no real financial cost savings, but what it was is a huge patient savings, because we saved 511 patients from having a dose of Demerol that they didn't need. You know, they were hypothermic, they were already shivering. Now we're giving them another drug that they're going to have to clear, and they're going to be in the PACU longer. They could get nauseous and vomit. So it was a win for us, because we had steady decreases of the doses of Demerol after we were warming our patients. And we do believe that the results accounted for implementation of the pre-op warming for all of our patients in the pre-op holding area. And of course, other things could come into play. You know, other patient and technical quality practices factors can be relevant. But like I said, we just strictly looked at numbers before we were warming and after we were warming. So our improved patient outcomes is that all patients having a surgical procedure are pre-warmed with our 3M Bear Hugger warming procedure. So I work at a orthopedic hospital that was strictly orthopedics, and so if you were having a foot case, you got the gown. If you were having a big scoliosis spine surgery, you got the gown. Everybody got it. And so that was a huge practice change for us, is to warm everybody preoperatively. And then we decided to use the Bear Hugger temperature monitoring system on all of our cases, except for our spine cases due to prone positioning and some of our shoulder cases. So with spine, obviously they're prone, their head is in a face mask. There's so many issues related to skin integrity in the prone position, and the sensor is only approved to be placed between the frontal sinus and the temporal area. So we didn't want to add another potential skin integrity issue to that. And then our shoulder cases, they're in a high Fowler position, and they have a mask that connects to the table to keep their head steady. And again, that goes across their forehead, and we didn't want to put a sensor on that and complicate things. So, and luckily in those cases, those are general anesthesia cases. So those patients get an esophageal probe placed, and then when they get to the PACU, we go back to the sensor, because then we can compare core body temperatures in the operating room to the PACU and have it be close. So my 3M rep was right that the BHTM system provided consistent temperature monitoring through all phases of the perioperative care, meeting ERAS protocols. We now have accurate temperatures for regional and MAC patients. And that was something that always bothered me, because our patients who were semi-conscious, there was no way to measure their core body temperature. I know in the past other hospitals have used these black things that go on their forehead, and it's kind of like a mood ring of temperature management, and it goes, if it's red, it's bad, if it's green, it's good, and if it's yellow, you're kind of in the middle. But there's no way to measure core body temperature with that. So patients who had spinal and MAC had no core body temperature going. We had no idea where their temperatures were. And now we do, because it's non-invasive. Our decreased meperidine usage in the PACU, we just talked about that. Blanket use. Logic would tell you that we didn't count all of our blankets, because there's lots of reasons that blankets are used in an operating room, whether it's for positioning. Sometimes they use it to clean the floor when they're doing scope procedures and there's a lot of water on the floor. So we didn't think counting was really going to make any sense, but these patients come in and they're in the pre-op area and they get hooked to their warming gown, and they really only need a blanket for privacy. And that's been a great thing, because lots of patients came in freezing into the pre-op area, and the pre-op nurses would just put tons of warm blankets on them. And the blankets would get cold, and then they would transfer them to the operating room, and we'd have to dig out the patient from all these blankets and throw them away and move them over to the stretcher. So, and then when they go to the PACU, they're back in their warming gown, and all they really need is a blanket on top of them. So there's definitely a decrease in blanket use than what we were doing before. The pre-warming can continue in the OR for patients needing extensive pre-op preparation. And this is huge for our spine patients that need neuromonitoring, or our patients who need line placement. This gown is designed so that you can hook your regular bear hugger up to it, and you can continue warming the patients while we're not ready to position and we're putting our needles in for neuromonitoring or putting lines in. And that's really important because like I mentioned, that redistribution temperature drop happens quickly in that first hour. So if you're not getting ready to warm your patients by positioning them, you really need to keep that warming gown on and warm them up. The patients are introduced to the pre-op warming process preoperatively. We used to have classes before COVID, which was great because lots of patients are visual learners and they like to see the gown and how it works. They do get it now as well, and it's important for them to know that this is a therapy. I think in the same regard, it's important for your pre-op nurses to know that too. They really need to be on board with this because it's not just for their comfort. You know, it's really because if we're warming them, we're going to help with that redistribution temperature drop. And, you know, through my time of implementing this, I've had pre-op nurses come up to me and say, hey, they don't want it. They don't want it, you know, and because I'll walk in and it's not connected. And I'll say to the patient, you know, can I turn your gown on for you? Can I connect this? And the patient was like, no, I'm really good, I'm comfortable. And then I tell them, well, you know, if we pre-warm you, you're gonna probably bleed less, your pain medication will work better, and you're less likely to get a surgical site infection, and I've never had any patient turn me down. They say, fine, hook me up fast, because they don't want that. They want to have their best outcomes. And so if you present that from your pre-op staff like that, and just say, oh no, this is just for your comfort, of course they're gonna skip it. But if they know that it's actually helping them in the long run, you have much more success with that. And the increased patient satisfaction, can't say enough about it. Patients love to be warm, even in the summer. We did this in the summer, the patients loved it. They come in chilly. It's amazing to see because it takes their stress level down huge. It just, you walk in and they're more comfortable, and it's kind of like, oh, okay, I'm ready. I mean, I've walked in and my patients have been sleeping and I have to wake them up to talk to them, and that like warms my heart because I'm like, wow, you're having this big surgery and you're able to sleep, and that's a really good thing. And like I said, the patients love it. Can't say enough about it. If you're looking to increase your patient satisfaction, I would warm your patients preoperatively. And as it turned out, I just spoke with one of my surgeons I used to work with who retired, and he was a grumpy old orthopedic surgeon, and he just came in and had a laminectomy done, and he said, Linda, I had that warming gown on, that it was really good. And I'm like, oh, okay, great, I'm glad you liked it. And I was kind of shocked from him because, like I said, he's a little grumpy. But the patient satisfaction is tremendous. And the best thing is before we now have accurate and consistent temperature monitor. Before we had apples to oranges, because those temporal scanner temperatures did not measure, not even compare to our core body temperature, and in the esophageal probe. And now we have apples to apples. We have the same device preoperatively, intraoperatively, and postoperatively. And I'm going to finish with my favorite quote: "Don't be afraid to give up the good and go for the great." And I'll take any questions or anything that you have, discussion, comments. Anybody use this? Anybody use Bear Hugger? Well, yeah, I mean, that's the key, because that's part of the teaching, is you have to tell them, I tell them you want to be warm enough so you're warm enough and you're not sweating, because now you're sweating and now you're starting to cool again. So, and actually some of the women I've put it on, were having hot flashes and they would put it on cool and it actually helped them. So, I mean, it works for the majority of people, and you know, they love to be able to control it because it's not just one setting. So they can kind of, if they want to be a little bit warmer, they crank it up. If they want to be cooler, they go down, but they're still getting the benefit of the pre-warming even on the colder end of that spectrum.
Yeah, thanks for a fantastic talk. We did use this in VCU, this system, and what we found good was it helped us identify which part of the path the patients were dropping their temperature. And it is right from the pre-surgical unit, so we started pre-warming as well.
Oh, you did?
One of the issues we ran into was with the infection control department, because we did all our blocks in the pre-surgical unit, and they weren't very keen on us using this because of the dust when you're putting needles in people's back and things. Do you know, is there any way to improve the connectivity of the device to seal so that you're not getting air spilling out around where you go into the actual blanket? Because that we ended up using tape to do that as a way around it. But I didn't know if there's other other things we can do to do that?
What we did is I don't know, I'd have to talk to 3M about that, because it is the connection that goes from the hose to the gown. But what we would do is turn the gown off and do our block, because we did lots of femoral blocks back then and for our total knees. And we did our spinals in the operating room, but we would just turn it off, and then the pre-op nurse would come back in and just turn it back on. And because the anesthesia was not happy about having to do blocks with this bear hugger going. And there is discussion about whether forced air can cause, a rise in infection prevention, but there's infections, but there's lots of studies out there that say that it doesn't.
Yeah, I think if you've got an open wound, it's one thing, but when you're doing blocks, you're just using a needle.
Right, exactly.
So it shouldn't really make any difference.
I think you could leave it on and just,
Yeah.
but sometimes because it blows up on the core area, they don't want to deal with it because it's going to get in the way of their femoral nerve block or something. So they would just turn it off, and then the pre-op nurses would go and turn it back on.
But I do agree with you, the pre-warming made an enormous difference.
Oh, I'm glad to hear that, because we saw it with our own eyes. It was pretty incredible, that redistribution temperature drop. And even though we had it in the second phase, the patient's temperatures came up quicker. So they didn't get that huge dump of their temperature. They kind of went down and came back up much quicker.
Yeah, thank you.
Well, thank you.
Thanks very much for a great talk. We've been using the warming blanket for years now, and so patients in pre-op don't get cold. The problem is they come back to the OR, which is cold. It's not plugged in again because our anesthesia team doesn't like the hugger blowing up in their faces while they're intubating. And then there's all this busyness positioning the patient, and even though they've had the warmer on in pre-op, they're still getting cold before they get draped. So we've just recently been looking at this because the ERAS interactive audit system is looking not just at temperature at the end of the case, but now it's looking at lowest temperature, and we're finding this. So we're correcting that. The other thing is our orthopedic surgeons don't like the bear hugger going on before the patient's draped, because as Mike said, air blowing over the operative site. If air in the operative site causes infections, we don't have a chance.
Sure, we would all be infected, and I try to tell them that. And but that is the real thing of anesthesia is tough. Like I said, I don't know who's in the room that's anesthesia, but they're a tough group, and they, I mean, it's great if you find some that are really, like I said, get that champion. That on the last talk I heard of getting in the kidney is pick champions, because they're the ones who are going to buy into it. But if you could keep the patients warm while they're being intubated and just put a blanket over it, it's a huge thing. But anesthesia can't get past it. And the orthopedic doctors, they're tough too. They're not happy with the bear hugger being turned on before surgery while the patient is being prepped. But there's really no documentation that says that, like that. Absolutely, absolutely. Yes, but I had a hard time getting it through to them. They put up with me because I was kind of like a junkyard dog and didn't give up, so they put up with me, but they, but they don't believe it. And it was hard. Anesthesia, if you got one doctor who didn't think it worked and disregarded it, like they said, it's like a cancer. It just keeps going and going and going. And it takes a lot of work to get people to focus on, we're doing this for the patient. It's the right thing to do. And it's hard.
So I'm an anesthesiologist. We do pre-warming as well, so I'm totally on board with that. I had a question about your meperidine study, and I know you said it was mostly retrospective and looking at total numbers. Did you do any sort of dissecting out the actual temperatures, particularly once you had the device, core temperatures in the patients who still received meperidine? Because there are several studies that suggest it actually has nothing to do with body temperature necessarily, but more about the crossing of inhalational gases across the hypothalamus. So I'm wondering if you were able to look at those numbers and see if that took any water on as part of that. We
did look at numbers for everybody who got a dose of Demerol. We looked at where their core body temperature was pre-op, intra-op, and post-operatively. I mean, it's interesting because some people didn't shiver with low temperatures and some people did. But we did look at it, we did lay that out a little bit on that. We looked at BMI, we looked at other things like that because Not a lot, not a lot. What was more surprising that was that patients were hypothermic and didn't shiver. You know, I mean, when we looked at our numbers, but actually that doesn't really make a lot of sense, but it depends on the depth of their hypothermia, you know. Some people were shivering at 96.4 and others were shivering at, you know, 96.1 or, you know, even lower, because we had a lot of temps in the 95, you know, range. But it's really helped us with us, and we're doing so many more spinals now with our ERAS protocols as they've evolved through the process. And so we wouldn't have had any way to measure core body temperature because all of our patients are having spinals, and we're just using this temporal scanner. And we all know with COVID, how many times have you had your temperature taken in the last year? And sometimes you walk in and it's completely off, you know it is. And it's all user dependent. It depends on if it's a laser, is it here, you know, there's no real way. So this system is amazing because you're getting accurate temperatures through the entire process. Anybody else have anything to add? Great, well, thank you very much. Hope you enjoyed your lunch.